Joe, did you want
Sorry,
me to share the PowerPoint, or did you want to do the share screen?
I can try. Let me try doing it.
Okay, if not, I'm happy to.
Okay, cool. Oh, it says the host disabled participant screen sharing.
Oh, you have to be made co-host.
Ah,
okay. You should be good to go now.
cool.
I'll just do a quick intro for our members. So hi everyone, my name is Zainab. Thank you so much for being here today. Thank you to our awesome doctors for joining us today. For those of you who are new to Mom's Corner, welcome. For those of you who are returning, welcome. And just a bit about Mom's Corner. We actually created it before the pandemic, and it's one of the many programs under the umbrella of Global Perinatal Services. And anyone who's not familiar with Global Perinatal Services, or GPS, it's a nonprofit, a local nonprofit who's doing a lot of great work. And our mission is to provide community-based doula services that will educate, respect, and empower low-income refugee and immigrant women and their families during pregnancy, birth, and into parenting. And Mom's Corner is not just for moms. We welcome all women folk. And this has just been a really a place for moms to come and connect and find friendships, community resources, support, and things like that. And as I said, it's all for all women, because at Mom's Corner, we believe that motherhood is an extension of who a woman is, and not a definition of who she is. And so we welcome all our members, our women folk from the community. So, and without further ado, I'll just give it to the doctors with the topic. Today's topic is VBAC.
Cool. Thank you so much, Zainab. Hi, everyone. So I'm Joe. I use she, her pronouns, and I'm one of the second year family medicine residents at Swedish First Hill. Super interested in OB and reproductive health care. And I'm here with maybe Maya and Claire. I'll let you guys just give a little brief intro of yourselves too before we get started.
Hi, I'm Dr. Siegel, but you can call me Maya. I'm also a resident at Swedish First Hill. I'm a third year. I'm a resident for another 3 weeks, and then I graduate, and my clinic's up in Ballard.
And hi, I'm Claire Thompson. I also use she, her pronouns. I am one of the family medicine faculty at the Swedish First Hill residency. Yeah, and as I said a couple of times, I'll just apologize in advance if I'm popping in and out, and we'll probably turn my camera off as I'm chasing a toddler around the house.
Cool. Okay, I am gonna share my screen. My messy screen, apologies. And
oh, don't click the share button, click the present button at the top right.
Oh yeah, there we go. Thank you. Cool.
I've done the same thing many times.
Love it. Does everyone see my screen? Sweet. Yeah, so as Zainab said, we are going to be talking today about VBAC, which stands for Vaginal Birth After Cesarean Delivery. I think this was a topic that the group from last month or the month before was requesting. Dr. Abraham, who I think you all know pretty well, made most of these slides, and then here are our names. And I
feel free to.
Slides.
Okay. And feel free to interrupt us with questions. This is meant to be a conversation and a back and forth. And so we love it when people have questions, or if you want something clarified, or if we accidentally used a term that was like medicalese and does not make sense to the average person, please let us know.
Totally. Yep. The slides are very much a guide and not a hard rule of what we want to talk about today. So just a quick overview of the things that we thought we'd talk about. We'll talk about some of the medical issues and evidence around VBAC, like what it is and kind of what we know about it. A little bit about health disparities surrounding VBACs and cesarean sections. And then at the end, we're really going to talk a lot about what questions we recommend people ask when discussing a vaginal birth after cesarean with your healthcare provider, and what questions you should ask yourself when you're making that decision. These are two of the acronyms that we're going to probably default to using a lot during the presentation. So again, VBAC stands for vaginal birth after a cesarean section. And a TOLAC is what it's called sort of like before you have had that vaginal birth. So when you're trialing labor after a cesarean section, but have not yet actually had the vaginal delivery, it's called a TOLAC. Any questions about that so far? Cool. Lots of words on this slide, but basically part of the reason that we're talking about this is because over the last like 40 years or so, the rates of C-sections have really increased a lot, from maybe about 5% to an overall 30% C-section rate in the country. This is due to a lot of reasons, a lot of mainly like increased fetal monitoring, or the fact that we are able to see when something might be sort of going wrong in a labor, rather when previously we were not able to see that. A decrease in operative vaginal deliveries, and then a decrease in attempting to deliver a baby vaginally from breech position. But overall, just kind of the non-evidence-based practice that would state and maybe encourage C-section as the best practice over vaginal delivery. So with this increase in C-sections, there's been a lot of research on what it looks like for people to have a vaginal delivery after a C-section. And those are increasing as well. And with that, we see a wonderful increase in the number of people who successfully have a vaginal delivery after C-section, as well as a number of complications from that, which we'll talk about later. We'll talk a little bit later about one of the main kind of like things that this issue hinges on, which is sort of the probability of a successful VBAC. And that's based on a model that includes age, BMI, in some models, race, and really the indication for your prior C-section. So VBAC is associated with a lot of really wonderful things. So there's decreased maternal morbidity, meaning like bad things that happen, and a decreased rate of complications in future pregnancies, as well as just being able to decrease the overall rate of C-section kind of at a population level. So the fact that we're able to talk about and offer VBACs has a lot of really wonderful, wonderful outcomes. If you have a VBAC, meaning you deliver vaginally after a C-section, you're avoiding this major abdominal surgery that a C-section represents. There's a lower rate of hemorrhage or severe blood loss with a VBAC as opposed to a C-section, lower rates of infection, and lower rates of blood clots. So the thing that medical providers, and I don't know if the photo is showing up here, but that's okay. The thing that for medical providers, the thing that we're often concerned about or sort of cautioning people against with VBAC sometimes is uterine rupture, which is the main sort of complication that a VBAC can include, which basically means your uterus where it was cut during a C-section, there's a scar there, and the scar would basically break or rupture, which is a big emergency, leads to bleeding and potential mortality for mom and baby. Also important to kind of note that performing, if you are doing a TOLAC, meaning if you are laboring after having a C-section and then something goes not according to plan and you do end up going to get a C-section, that is a higher risk experience than if you had just had a repeat C-section from the start. So that's sort of an important thing to recognize as well. Both C-sections and VBACs carry risks. Like a planned repeat C-section also has some of the risks that we talked about earlier with like hemorrhage, infection, operative injury. And it's important to note that most of the mortality and like poor outcomes with TOLAC happen once you go to a C-section or once you have had a failed VBAC. But if you are able to have a successful TOLAC and you have a VBAC, then it's great. And you minimize the risk of all of those morbidity and mortality things. So because the safety of the birthing parent and baby really depends on how successful the VBAC is and whether or not you're actually able to move towards a vaginal delivery versus go to a C-section after laboring, we use a lot of clinical calculators to sort of give us information about how high your chances are of having that successful VBAC. And we'll go through one of those calculators in a little bit, but if you are sort of consulting with the provider about whether or not it's recommended that you try to have a VBAC, they will very likely go through one of these calculators with you and give you sort of a percentage or a probability of what the success rate might be. It's important to take any sort of model with a grain of salt because nothing is like shown to be 100% accurate.
I think also talking about that last point, not only has it not been shown to be accurate, but also hasn't been shown to improve outcomes. So these calculators were created to try and determine if someone wanted to have a TOLAC and try to give birth vaginally, what is their chance of success to try and avoid the complications of having a C-section after they've been laboring for a while, because that is when it's more dangerous. And so trying to then funnel people saying, you guys can go and try to have a vaginal delivery, you are too risky. It's important you just go to a C-section, and we recommend that you don't even try. And these calculators have been in place, but even though we've been using these calculators to help make medical decisions, there haven't been shown to be any reduction in complications or any improvement in outcomes, even when we've been trying to funnel some people saying it's riskier and like trying to make it so only the ideal candidates are getting TOLACs. We haven't changed outcomes, even though we're now using these calculators to kind of tell people what to do with their lives.
Cool. Thanks, Dr. Siegel. So this is one of the calculators that your provider may use when talking to you about your probability for VBAC success. It includes age and height and weight, which will kind of, calculate your BMI overall. Your obstetric history, so whether or not you have had a VBAC in the past. If this is like your second VBAC, that will go into this calculator and very likely give you sort of higher predicted odds of having another successful vaginal delivery after C-section. And then this question is asking about why you had a C-section in the first place, which is a really important part of this entire conversation with your provider, because the indication for your C-section matters a lot in terms of these calculators and how they're predicting probability for success in a vaginal delivery. So the big thing is, was there arrest of cervical dilation or arrest of descent of the fetus into the pelvis, causing the recommendation for a C-section? And if so, that might sort of tip the calculator in a lower sort of odds of probability for having a successful VBAC. And we'll go into those definitions a little bit more later. Whether or not you're being treated for hypertension also goes into the calculator as well. So just some facts about these like scary things that we're talking about in terms of like uterine rupture and the dangers of VBAC. The complication rates are actually quite low. So it's 1 in every like 238 labors after C-section result in a uterine rupture, leading to an emergent C-section. And actually like quite rare for baby to suffer mortality because of this. It's about 1 in 5,200. And then just important to know, so if you experience a uterine rupture, meaning if that scar is sort of giving way and weakening as you're laboring on your uterus, many times that will require an urgent hysterectomy or removal of the uterus, which is the same, the sort of risk for that is actually the same risk for hysterectomy as having a repeat C-section. And Dr. Siegel, I think that is maybe where you were going to take over.
Yeah.
Cool.
And then one thing I wanted to comment on the previous slide of, I think it's important that if you are thinking about doing a trial of labor, to really strongly consider doing it in a hospital as opposed to doing a home birth, because part of the reasons it is rare that the baby dies and it's rare that the mother has a complication is because if there is a rupture, that is an emergency and you need to have a C-section right away. Because a rupture means that like the uterus, the scar tissue in the uterus is not as strong as the muscle of the uterus, because the uterus is a giant muscle. And if that breaks away, the baby has now left the uterus and is now hanging out in your abdomen next to your colon, next to your other organs where it does not belong. And that can cause a ton of bleeding. And so it can be really dangerous. So if you're thinking about doing a trilacc, it's wonderful, but be in an area where you can get help if something goes wrong. And so doing it in a hospital setting is often safer. And so there are some reasons why your doctor may say, hey, a VBAC is not good for you. And I brought the picture of the scars again. Part of that is the one on the right, the furthest right, where it's a scar that goes across like this. That is the safest one to do a trial of labor. The scar tissue right there is smaller and also less likely to rupture during labor. Whereas if you have a classical scar, which are these two on the one on the far left is the classical, and the one in the middle is a bit more of a modified, but any scar that goes up and down in your uterus is much more likely to rupture. And so in most places, if you have a classical scar, or if you don't know the shape of your scar, so if you don't have access to the medical records, or you can't get those previous medical records, if they're maybe outside the country, you don't remember the hospital, then people usually recommend against it, just in case it's those previous type of scars. Nowadays, almost all C-sections are the scar that go across like that, which allows for a VBAC unless there's a complication where they have to do a classical scar if there's something going wrong. Or if the scar extends further in the previous C-section, that might make it the scar too big and then therefore be more dangerous. Additionally, if you've had a short interval between pregnancies, meaning that it was only about 6 months, like the strongest rule is if it's been 6 months after you delivered when you conceived again, that doesn't give the uterus and that scar enough time to heal and get strong. So the scar will always be weaker than the muscle, but you may also notice if you've ever gotten a cut on your hand or something like that, when you first have a scar, it's much weaker and it's more likely to open up. Whereas if you've had a scar for many, many years, it's not going to open. And so having that short interval pregnancy, that scar is just so much weaker that it's can be dangerous. And then kind of we say the medium chances, and these are the ones that are often used, but don't have as good of evidence. These two at the top have good evidence, is that people say your baby is bigger and therefore that'll be more stress on your uterus, or they use the calculator and it says it's a low risk. And then part of that is keeping in mind is the calculators aren't perfect. And so really having a discussion with your doctor. Next slide. And so part of one of the biggest factors in these calculators is the arrest of labor. And there's two types of arrest of labor that we think of. One of them is called arrest of dilation, which is your cervix is not opening and it doesn't open for more than it doesn't change even if you've had 4 hours of adequate contractions, which means they're measuring the contractions with the catheter inside you, or 6 hours and no change, and they aren't measuring it with a catheter inside you, and they've tried giving you Pitocin or something to help strengthen your contractions. And usually if there's arrest of dilation, then the other one is arrest of descent. So you got to fully dilated, you got to 10 centimeters, your cervix is open, and you've been pushing, and pushing, and baby is not coming down. And then that causes a C-section. If those two were one of your reasons for having a C-section, your chances of having a successful vaginal delivery afterwards is less likely because it's because you didn't have a successful vaginal delivery beforehand. Something was probably just with the match of your baby in the pelvis, something wasn't working that day. But if you had a C-section for a different reason, so in the US, very few breech babies, so babies that are butt down instead of head down, are born vaginally. And so if a breech baby was the reason for a C-section, it wasn't that you tried and failed to give birth vaginally. And so your chances of giving birth vaginally in the future are better. Or if your reason for a C-section was that a baby didn't tolerate labor early on in labor, and so you had a C-section due to fetal distress, that also is less likely to affect your chances of a successful vaginal delivery before. So kind of the thought process is, if the reason you had a C-section is because you tried and you weren't able to do a vaginal delivery after you tried, the chances of you trying and not succeeding again are higher. And a lot of these calculators, they're not perfect. And a lot of them in the past included race and ethnicity as part of the calculators. And all of the calculators that included race and ethnicity had it so Black women had a lower percentage of being successful. And therefore more Black women were being told that they couldn't try to have a VBAC, or they couldn't have a trial of labor after cesarean. And so more and more were having C-sections, which also results in more complications, more longer recovery times, more blood loss, and things like that. The newer and often those use of race was kind of a proxy for other things like socioeconomic status, support that they had in labor, access to doulas, and things like that, which are not related to race in any way. Since 2021, there's been some newer calculators that do not include race in the prediction models, recognizing that these were flawed and racist. And part of the reason that the maternal mortality in the US for Black women is so much higher is because of those higher C-section rates. And so by removing race from the calculators, hopefully that will allow and enable more Black women to have vaginal births after C-sections if they want to, and lower the complication rates of having a C-section. And so kind of looking in the past, a lot of people, when they ask about a VBAC, are told they can't, unfortunately, in this country. And in a survey almost a decade ago, about half of people who were considering one were told they couldn't. And that 1 in 4 providers and 15% of just hospitals in the US do not even allow it and do not allow people to attempt. And so, when people have discussed it with their providers, a lot of providers expressed a preference for a repeat C-section. We already removed race from the calculator. They removed it last year. It was too late, but they got around to it finally.
Sorry, is that the American Medical Association that created this calculator?
I believe the calculator was through ACOG, which is the American College of Obstetrics and Gynecology, but there's a couple different ones that exist, but Claire might know better.
Yeah, it's MFMU, is the Maternal Fetal Medicine Society.
And is it, sorry, doctor, go ahead.
No, please go ahead.
Yeah, so they're not inputting just like numerical values. Some of the questions are, they're asked to, like, they don't give a number, but they're asked, like, the example of, have you had a C-section before? And they just kind of put those values in, but they're not all necessarily numerical, the answers.
So the output is numerical, but the inputs are not always numerical. But that's also because you can't give a reason as a number of, like, the reason for C-section. Also, number of previous C-sections is often put into the calculator, because the more scar tissue you have, a lot of people, if you've had 2 C-sections, might say you can't, because that scar is just weaker every time.
Yes.
And so, and there's some hospitals just don't even allow it. And part of it is, in the US, especially within obstetrics, a lot of people, it's very unpredictable, and the unpredictability can be scary. And a lot of people in this country sue when things go wrong. And so having a repeat C-section allows it to be in a very controlled environment, and the uterus is easier to operate on, and it's a less complicated surgery if the uterus hadn't gone into labor. And so that's why often people seem to prefer to have the repeat C-section, even though it does have the increased complications, bleeding, infection, clots, and it's a major abdominal surgery. And even though it's higher risk, it's something that's happening in a controlled setting. And so that's kind of why a lot of the medical field has shifted that way, because although there's still a lot of unknowns, it then feels like you can control more. even though we know that if someone has a successful birth after cesarean, that is a better outcome overall. So things that you should ask your doctor if you're thinking about having a vaginal birth after cesarean, ask them what's involved in the laboring process and what is involved in having a repeat C-section. And that includes asking, what does the recovery look like? How much pain am I expected to be in? The recovery from a C-section is most people say it's much harder than after a vaginal birth because you've had major surgery. You can't lift things, and it's hard on your body. Ask them, is there anything about your specific situation or pregnancy that then you need to consider? Is there something else going on with your pregnancy that makes you higher risk or makes it more dangerous, such as having hypertension? And then these last 3 questions are really great because I think it's really asking your provider what they're not telling you. So asking what are the possible risks and benefits of following their recommendation. If your doctor says, hey, have a repeat C-section, or hey, I think it's great to have a trial of labor after cesarean. But then also ask them, what are the pros and cons of the options you're not recommending? And so that way you're really able to have a full informed discussion with your providers, because it's your body and it's your choice. And then also some questions for yourself to think about is thinking about why you might choose a VBAC or why you might choose a repeat C-section. So if you're having a VBAC, you're more likely to have a shorter recovery and a shorter hospital stay and a faster recovery. You can return to your usual activities sooner. You're less likely to have surgical complications. You're also more likely to hold and nurse your baby sooner because you haven't had major surgery, and you're not, and part of that is that babies born from C-section also have higher risks of going to the NICU or higher risks of breathing difficulties. And then you're also, future pregnancies are safer. The more times you've had C-sections, the higher the chance that you have placental problems in the future with future pregnancies. And one of the biggest risks is that placenta growing into the scar, which can be really dangerous and cause a lot of bleeding, and also will often cause you to have a hysterectomy after that birth. And so if you're planning on having a lot of children, trying to have a VBAC is probably safer because then you're not repeating that scar and you're making it safer for future pregnancies. And that in one large study, people who had a VBAC rated their birth experiences more positively than those who had a repeat C-section. And so there is an association of a greater positive birth experience. And then some reasons someone might choose to have a repeat C-section instead of choosing to VBAC is that they're more nervous about the uterine rupture and they want to avoid that. And they want to avoid an emergency C-section. They feel that if they're going to have a C-section, they might end up having a C-section anyways. They would like to have it planned and be in a much more controlled environment. Because about 1 in 4 people who try to have a vaginal birth after cesarean will end up having a C-section anyways, which is similar to the number of people who, if they've never had a C-section, are trying to give vaginal birth, will have a C-section. But having a C-section after labor has begun is associated with more risks because the uterus has become more stretched and the uterus has been working because it's a muscle. And so having a C-section before labor is more controlled and is safer. You can also then plan the exact day your baby's going to be born. And you also really know what to expect from surgery, and kind of it feels like there's more control in the process. And so a lot of it is deciding within yourself, like, what are your goals and what is best for you? Because I am not here to tell you that a repeat C-section is better or VBAC is better. It's what is better for you, because it is your life and your pregnancy. And then we also wanted to share some really good resources if you want to learn more about VBACs. VBAC.com, childbirthconnection.org, ACOG, which is American College of Obstetrics and Gynecology, and also Power to Push is a really wonderful organization.
I wanted to add, some of the resources that most doulas use, or most of the out of hospital births, is a site called Evident Base. Have you all heard of that? Evident Based Birth?
Yes, I have. It is wonderful. That should be on this list too.
Okay.
It does such a good job of saying like, there is actually evidence for this. Nope, there isn't evidence for this other thing, but that's what everyone does. And they break it down really nicely.
Yeah, that's the one we encourage our doulas to sort of, because it's easy for, for everyone to sort of follow.
Yeah.
Even people who are not used to, published articles. So yeah, just to sort of show the clients, if they're resistant on certain things, to say that there's actually research, sound research that's also agreeing with the providers or things like that.
Mm-hmm.
I think that was all all of the structured slides that we had planned. I guess the only other thing that I'll add is that, so in our family medicine practice, and in many of the midwifery practices around Seattle too, if we have a patient who is interested in a VBAC, we do recommend that they have a formal consult with one of the providers in the area who is actually trained in C-sections. And so we have a couple family medicine providers who do VBAC consults, as well as the maternal fetal medicine group at Swedish where we work. And so if you are working with a midwife or a family medicine provider who doesn't do C-sections, and you want to you're interested in talking about a VBAC, they will likely recommend that you consult with one of those providers, just as part of your prenatal care, just as a heads up.
Yep. And then one other thing to think about, if you are planning to have a VBAC, and there are certain things, if you end up needing to be induced for labor, if you don't go into labor on your own, it's, 41 weeks, or you have a medical condition that encourages you to be induced earlier. The certain medicines that we normally use to induce labor, we can't use if there's a scar on the uterus. And whether that be a VBAC or you've had uterine surgery in the past, I mean, a C-section or other uterine surgery. And so it often can make the induction less successful because we can't use all the tools we usually use. We can't use misoprostol because it can soften that scar. And so that might also be something that shifts people who may have been thinking about one to then choose not to, or but really it's a conversation with you and your doctor or midwife or whoever's your birthing provider.
What questions does everyone have? Or comments, thoughts? I would love to hear just about people's experiences, both like learning about VBAC and in talking through this with some patients that you've worked with.
I think you kind of hit on all of the questions we had written down prior to our session, but now going into like after delivery, what things are moms allowed to do after the baby? Like, can they do skin to skin, things like that after that?
Yeah, with a VBAC, definitely, as long as there's not a reason that baby has to go to the NICU. And then after C-sections, in a lot of places, you can do skin to skin immediately, as long as the mother isn't too nauseous and like actively throwing up or anything that would then be dangerous to put baby to the skin. And a lot of places try to do that as soon as possible because it is that golden hour is so good for connection and for both mom and baby's health.
Absolutely. And then I guess for Swedish or other if you know other hospital policies, like how many people are allowed in the OR, or if it does happen?
Yeah, I think currently it's just one person is allowed into the operating room, and then in the delivery room, if it's not a C-section, you're allowed to have 2 people.
2 people. Okay.
Yeah. With COVID, it's changed a few times, but I believe the most recent one is 2. And if you have a doula, that counts as one of those people.
Or an interpreter, right?
No, the interpreter does not count as one of those people.
Cool.
Because that is a medical staff.
Right.
I'll add that we've had in some of like the policy meetings at First Hill that I've been at, we've had a lot of discussions about having 2 people allowed into the OR, like both a doula and a partner, and it's kind of gone back and forth. And I think right now it's still just one person being allowed, but that it's okay, like if the birthing parent in the C-section is nauseous or just it's hard logistically to do skin to skin with the birthing parent like immediately after delivery, then the other person can go skin to skin. Like you can put the baby skin to skin with like the partner, and then kind of zip up the little suit that they're in. It takes a little bit of logistics, and sometimes I think every once in a while there's like an anesthesiologist who isn't familiar with that, or one of the nurses who isn't familiar with that. But if that happens, that's definitely something to kind of like notify the charge nurse about, because or sorry, if someone's not letting you or one of your clients do that in the OR, like we've had a lot of discussions about the importance of the golden hour, even for patients who are getting C-sections. And so you should be allowed to do skin to skin with like the support person if they would like to do that.
And then the question about having multiple VBACs. If you've had one VBAC, your chances of having a successful VBAC after that are even higher. And so I have not heard of anyone saying you've had too many vaginal births after cesarean. I have heard though that if you've had too many C-sections, that that having a trial of labor after cesarean would be too much, and that would be too risky because that scar has formed a couple times. But I know of some patients who've had 4 or 5 children. Their first was a C-section, and everyone after that has been vaginal.
I think I saw a question before that as well from Taylor. I'm not sure if we addressed it.
I think we addressed a bit of why a doctor might rather do a repeat C-section and not a VBAC. It's a more controlled environment. It's a easier surgery and therefore less surgery that's less likely to have complications. If someone doing the C-section without the uterus having been in labor, compared to attempting a vaginal birth and then having to do a C-section after the uterus has been working for so long, it's a more complex surgery that is more likely to result in complications, and that there's often more unknown unknowns. And so often people would prefer the known risks of doing a repeat C-section, but doing that in such a controlled environment compared to the unknown risks that might happen from doing a trial of labor and not succeeding. Because about 1 in 4 people who try to have a VBAC end up with a repeat C-section anyways.
And do you think like in some instances that might have to do with the doctor's experience with it, or just like them not wanting to really like be liable for that kind of thing happening and just going with the easier option?
Yeah.
Yeah.
Oh, I think that's a huge part of it. The liability in how we practice medicine in this country in a defensive way, doing things that might not be best for patients, but are less likely to get people sued, like, is a huge one. And and if people are less comfortable with it, if they've had less experience doing emergency C-sections, they've had more experience doing scheduled ones, they might feel less comfortable with someone laboring. Those can all contribute to it.
Yeah. And I think just our perspective on like pregnancy, seeing pregnancy more as like another condition, medical condition to be treated and not something natural. Especially I think doctors, that's their mindset. And naturally OBs are surgeons, so they would likely kind of, go towards the option of a C-section. That's because they're surgeons, right?
Yeah, it's also always so interesting comparing the way that our system works compared to others. Like I had a friend who was a medical student in the Netherlands, and during her OB rotation, she didn't attend any vaginal births because there it's midwives who do all the vaginal births. And the OBs only come in for C-section or to do an operative, but anyone who's having a normal vaginal birth, it's a midwife. Why would you need an OB? The OB is busy doing surgeries.
Absolutely.
They just have a ton more midwives. And I think that also really changes the focus and the kind of what you're bringing to the experience as a provider.
Absolutely. Yeah.
Oh my gosh, I have so many dreams about the future of our maternal care in this country. I don't know if any of these dreams will come true, but yeah, more midwives, de-medicalizing pregnancy and childbirth.
Is that in the chat? I can't see the
Yeah,
chat.
it says, what are your dreams for the future of our maternal care system?
Oh, amazing.
Yeah, demedicalizing it, like empowering patients more and not having us come in and say like, this is what you need to do, but really encouraging people to advocate, adding nitrous oxide and other forms of pain control. So that way it's not epidural or nothing, but things that you can turn on and off. So that way people can still be super mobile, allowing everyone to have a doula, resources for that, because that just improves so many birth outcomes. Like also not charging so much money to give birth in a hospital, like making all prenatal care and deliveries free.
Longer prenatal visits, more group visits to give patients more time to ask questions and get to know their provider for sure.
Yeah. Paid maternity leave so people can actually take care of maternity and paternity leave. So both parents can take care of their baby after baby is born and people don't feel like they have to go immediately back to work.
I love these. This is awesome. This is exactly what the type of mindset that we need. Oh my goodness. Yeah, you all should be talking to lawmakers, honestly.
We do at least once a year at the Family Medicine Advocacy Day in Olympia, but yeah.
I do always wonder, like, I guess a woman, like a woman of color and a mom, like, what are, white doctors doing? It's kind of like the day-to-day, like, is there a space where you feel like, okay, I have a chance to advocate for my patients, and not wait until all up the day to Olympia? I guess that's what, are you constantly in this state, like, where you want to make change and you're pushing for change in your own small way, but do you know what I'm saying? That makes sense. But
yeah, of trying to both advocate for systemic change, but then also advocate for the patient in front of us.
Yes.
And sometimes when our energy is being pushed more towards systemic change, which will help more people overall, we then our energy is taken away from the patient in front of us. And there's constantly that pull throughout medicine, both in like pregnancy care, prenatal care, and elsewhere in medicine. And it's our system is fundamentally flawed. And we say it's a broken system, but it's not, because it was designed this way and it was designed to be oppressive. And it's functioning the way that it was designed to be, but it's terrible and we need to change it. But
absolutely,
with the way that insurance companies exist and the way that our country exists, I have trouble seeing the changes that I hope for.
Absolutely. I think the major problem of it being is, putting profits before people.
Yeah.
Just in everything we see dollar signs, and that's unfortunately why there's not a lot of systemic change, and it won't happen, like, for a long time if it does. Yeah. So, does anyone else have any questions? I think doctors kind of hit on all my questions, Faiza. Why aren't more moms choosing VBAC? I think we addressed that, right? Why aren't more moms choosing VBAC? I think we got that one.
I didn't see that question. I said,
it's one of mine.
Oh, why? Yeah, I think because often they're counseled against it, or they're not even presented as an option. And I think that we don't always have the time to have these deep and meaningful discussions about risks and benefits in the short prenatal visits that we have. And that's part of why we try to, if someone's interested in VBAC, have a consult where they have a visit entirely discussing the risks and benefits with a provider. But I think some people might operate in a system where they don't have that and they can't ask, or they aren't able to have these more nuanced discussions about what people's wants and desires are, or they might live in a place where the hospital just says, no, you can't.
Something. Sorry, I just lost my window.
Well, thanks you guys. Thanks everyone. This was really fun to talk to everyone. Are there ideas about what topic we should be thinking of covering for next month?
Sorry, doctors, I lost my place. Yeah, we do have, can you still hear me?
Yeah.
Yes, we do have a topic in mind.
Oh, cool.
I'm not sure if we settled on it yet, but yeah, Faisa, do you want to say? Oh, dear Lord. Okay, here I am. Ooh,
You go,
too
you go
many
ahead.
windows. Yeah. Oh my goodness, I was lost in my own computer. Okay. Sorry. Yeah, so we were thinking about, since it's like a hot topic right now, and it affects so many people, so many women's lives, abortion is the topic we want to consider talking about next time.
Cool. And
Yeah.
within that, are you interested in more learning of like what an abortion looks like, or what like is legal about an abortion, or just kind of like just so we can make sure that within the hour we cover what you want?
Yeah, just I think like the types of abortions.
Great.
Yeah, I think that would be a good focus. Yeah, starting point. Yeah, and if
Yeah.
we have time, policies and why there's such a polarization about the.
Yeah.
Yeah, we can
Oh,
do the basics of like medical and procedural abortion and yeah, some of the medical considerations of both.
yeah. Sorry to miss that one.
Oh yeah.
I would have had a lot to contribute.
Oh, we will miss you so much, Dr. Siga.
Yeah.
You weren't even here these past couple of weeks, so we already missed you. No, no, it's
I
like
know.
that.
I was actually in Arizona for a few weeks getting some abortion training.
Wow. Mhm,
And in the month before I was, yeah.
mhm.
At the end of residency, things just seem to get busier, and I don't know why.
Absolutely.
Yeah.
Mhm.
But it's been really a pleasure to be able to spend the time with you guys and participate in these teachings, for the past year and a half. So thank you for allowing us to be a part of your community and allowing us to share the knowledge we have with the questions you have.
Absolutely. It's just an honor to have all of you guys. And Dr. Sigal will miss you so much because I know you're going to make a huge difference in the world. So I'm just glad that we're able to share this experience with you for the short time that we have and your amazing knowledge.
Yeah. Well, you guys also do so much work. We're just here to support you guys.
Oh, thank you. Yeah. Faith, did I
Thank
send
you
out
so
all the
much.
links on there? The survey. Oh, the survey. Yes. Mhm.
The survey. Yeah. Thank you so much, Dr. Maya. This was a pleasure, and we wish all the best for you in everything that you do. And thank you for everyone too, all the other doctors, for showing up and, giving us an hour, 90 minutes sometimes of your time. We really appreciate you.
Yeah. And you've got Dr. Joe for at least a whole nother year. So
Hey.
yeah. And Claire isn't leaving anytime soon because she's faculty.
Claire and her little cute boy, 18-month-old boy. Yeah. Yeah. Yeah, I think we'll call that a wrap. And thank you guys so much, and have a great rest of your night. Thank you.
Good to see everyone. Thanks so much.
Oh my gosh,
Bye,
the
guys.
cutie is back.
Thank you for having.
Oh, there it is. There he is.
He was running around yelling things for a lot of time, but he enjoyed it.
Yeah, that's what they do best. Yeah.
Awesome. Well, have a good
Bye, baby. Bye, guys. Thank you. Yeah, bye.
All right. Bye.